So we gonna merge the couple of talks for Dr. Concepcion in one talk, just to stay on schedule, and I'm gonna cancel mine. So Dr. Concepcion was the medical director of kidney transplant in Vanderbilt, and recently moved to University of Chicago to take the medical directorship. She has been very involved in National Kidney Foundation, and she will talk about elderly candidates, referrals, and expectations.
Thank you, Dr. Al-Muhammad, for the invitation, and very happy to be here. So I'm going to merge this talk with the high KDPI talk, which are actually two related talks anyway. Trying to figure this out. Okay. So I'll start with a case. JJ is a 74-year-old female with ESRD secondary to diabetes and 3 times a week HD for a year. Now referred for kidney transplant evaluation. She has coronary disease and heart failure. She's not been hospitalized in the last year. She's independent in her ADL. She uses a cane when she walks, and now she's interested in pursuing kidney transplantation. So more and more, this is what we're seeing in our clinics. So what I'll briefly go through would be why pursue kidney transplant, who's an appropriate candidate, and how do we get this patient to a transplant. I don't think any transplant symposium is complete without showing this slide. I don't know if I'm the first one to show it, but again, we all know about the survival benefit of transplant compared to remaining on the waiting list. In this study from 1999, it's important to just note that there were actually about 3,000 patients who were 60 years old and older, and this is the first study that showed that transplant actually provided prolongation of life from 6 years to 10 years in this older population. But of course, there are other reasons to pursue kidney transplant: improvement in quality of life, freedom from dialysis, ability to travel, and even reduced dietary restrictions. And if you ask patients, elderly patients who've received transplants, they'll say, "I feel stronger and younger all the time." And just to read to you one of the quotes here, "It is being alive. I have been free. I feel healthy and well and energetic, and feel like that when you have it, the life I have is pretty marvelous. You're living in the moment now." But what we have right now is a greater number of older candidates and recipients who have higher burden of comorbidities, and we're using more and more what we call quote-unquote marginal kidneys. So I'd like to just briefly review the literature on survival, and I think this is the US study that you've probably all seen in over 65 and older, 25,000 patients. And what they did here was they stratified the recipients based on cardiovascular risk, being low risk, intermediate risk, and high risk. So if you had 0 risk factors, you were low. If you had 1, you were intermediate. And if you're high, you had 2 or more. And all diabetics were considered high risk. And what you see here is that with a living donor transplant, there's immediate benefit for low risk and intermediate risk candidates. And then as you go down to standard criteria and extended criteria, you see here that the time to equal risk of death varies. But in all cardiovascular risk groups, transplant was associated with long-term survival advantage compared to dialysis. Again, there were marked differences in time to equal risk of death and time to equal survival by donor type. I'm going to skip this. So this is the latest paper that just came out, and this was just published in AJT. This is looking at survival in recipients over 70 years old. This is from the Australia and New Zealand registry, looking at candidates from 2009 to 2019. They matched kidney transplant recipients to waitlisted dialysis patients. They had 465 pairs, followed for a median of 1.7 years. And what you see here is a 5-year survival benefit. Kidney transplant recipients had 80% survival, whereas the matched pairs had survival of 53%. And similar to the curves I've been showing you, adjusted for sex, BMI, smoking status, diabetes, cardiovascular disease, and chronic lung disease, you see that in the beginning there is this higher risk of death, but over the long term you see survival benefit. And in this cohort, mortality was 38% lower for kidney transplant recipients compared to those waitlisted patients. And again, similar to the Gill paper, what you'll see is that living and standard criteria donor recipients had immediate survival advantage, whereas the ECD recipients took 17 months for them to negate that increased risk of death early on. So, who is an appropriate candidate? This is the 2020 KDIGO clinical practice guideline that says consider age in the context of other comorbidities, including frailty, that may impact outcome when deciding about suitability for kidney transplant. We recommend not excluding patients from kidney transplant because of age alone, and that's a 1A recommendation. And as we know, there are many things to consider in an older patient, whereas it's frailty, social support, cognitive status, and of course, your cardiovascular infection and cancer risks. But there's no universally agreed upon age cutoff. Seems that if predicted medium to long-term survival is reasonable, then a patient should be considered having acceptable global health, adequate support, and able to adhere to medical therapy. And in the survey from 2017, when they looked at what transplant centers are actually doing, 59 centers responded, only 22% had an age cutoff, and that cutoff was a mean age of 79 years. So we have to think about physiologic versus chronologic age. Certainly not every 74-year-old is the same. There are clinical risk score predictions that these are from my colleagues at University of Chicago that looked at a lot of clinical variables and sort of looked at outcomes and have this tool for predicting this risk score to see how many patients will, of the risk factors, what is your survival at 5 years? And because the median waiting time is about 4.5, seemed like these are people who would still be predicted to be alive at time of transplant. So a predictive risk score can provide some guidance in selecting patients who are appropriate to even undergo a transplant referral. Frailty, we talk about a lot. There are different frailty scales. So here you have on the table on the left side just questions that you ask, and based on that determine frailty. Or you can do, the testing, which involves looking for weakness, exhaustion, walking, physical activity, and shrinking. But for the most part, frail individuals are most vulnerable to the numerous health stressors of kidney disease, and we know that frailty is associated with post-transplant outcomes. This is a review that was led by Dr. Harhe, looked and summarized frailty as that the ideal frailty metric is really unknown. Frailty is common among our patients with numerous negative implications. Periodic assessments and interventions such as prehabilitation may mitigate these adverse outcomes. And although frail individuals with advanced kidney disease may benefit from kidney transplant over dialysis, frailty may actually reduce the likelihood of receiving KT. So it might actually be a barrier for us to consider patients who we think are frail. So back to the case, our 74-year-old underwent standard pre-transplant testing. She's blood type O, she's unsensitized. And we sent her to a successful aging and frailty evaluation clinic, which we have at the University of Chicago. It's pretty comprehensive assessment, and just to show you what that assessment looked like, included frailty evaluation, a short physical performance battery, a survey for vulnerable elders, looking at cognitive function, social support, gait and balance, falls, polypharmacy, and an assessment of multimorbidity. And this assessment was based on this comprehensive geriatric assessment. The patient's an average to above average risk surgical patient. They had some specific recommendation, but ultimately, patient appears to be a good candidate and was approved for listing. So that's one hard part about being an older patient, is even just making it through the evaluation, right? So now that you are on the wait list, what are you looking at as this patient is? Well, these are the outcomes after waitlisting based on USRDS annual data report. And what you see here is that a good number of patients at 3 years are going to be removed or would have died after being waitlisted. So these patients will actually never get to a transplant. So we feel good that, we approved them, we put them on the list, but really what they need is a transplant very, very soon. So how do you get to a transplant? Well, clearly the answer is living donor transplant, which provides immediate transplantation and reduced risks. But the other options are to go for a high KDPI kidney or other kidneys that perhaps have a shorter list. And whether it's not visible in the UNOS match run, you know that these are kidneys that are more likely to be turned down by centers such as donors that perhaps have COVID or have AKI or are older deceased. ECDs. And then there are the standard kidneys. So we talked about how living donor transplant provides the best outcomes. I already showed you these studies, and it's because it allows for timely transplantation and provides that immediate survival benefit. As far as living donation, I think in older patients, it's important to explore options, including older living donors. This is a study that shows that older living donors over 55 years, outcomes are superior to even ECD or SCD. And even in greater than 70-year-old patients, 70 years or older living donors is superior to an ECD transplant. This is a study that shows you that these kidneys that are perhaps high KDPI can provide a lifetime of allograft function for patients who are older. So this is a study of patients who are waitlisted patients who are greater than or equal to 65-year-olds. Actually, they received transplants, over 5,000 people. And what they saw here is that on the right table, you'll see that the 10-year mean patient and death censored graft survival and the difference between the curves. So in the older patient populations, you'll see that those gray curves are higher than the black curves, telling you that essentially the graft outlives your older patient. So back to the case, this lady did not have any living donors and she consented to offers for KDPI greater than 85%. So I'm going to move on to the next talk, but to conclude this section, in selected elderly patients, kidney transplant confers a survival benefit over remaining on the wait list. Appropriate selection likely includes special consideration of cardiovascular and infectious risks, in addition to assessing for frailty. And living donor transplant, including donation by older donors, is by far the preferred option for elderly candidates.
Dr. Concepcion will continue in her second talk about the height use of the KDPI.
All right, so I'm going to just keep on going. So we want to understand why accept high KDPI kidneys, select the appropriate recipient, and employ interventions to reduce complications. Just as a reminder, KDPI is a numerical measure that combines 10 donor factors to summarize into a single number the quality of deceased donor kidneys relative to other recovered kidneys. It's derived from the KDRI, which is a relative risk scale. And the reference population is all the deceased donors in the U.S. in the prior calendar year. So as you see here at the graph on the right, the lower KDPI is associated with increased donor quality and expected longevity. So let's go back to the case. She has no approved living donors. So I showed you this as far as what outcome she's looking at on the waiting list. And this is a slide, a screenshot from the SRTR website where you can go and basically help your patient weigh pros and cons. And so pros and cons for willing to accept a high KDPI kidney would be a shorter wait time because of access to more donors and a higher survival rate compared to dialysis for many patients. And the cons would be the kidney may not last as long because of lower quality. If you're not willing to accept the high KDPI kidney, the pros would be the kidney generally lasts longer because of higher quality. The cons would be that the longer wait time because of access to a smaller pool of donors and potentially lower survival rate due to longer wait time on the waiting list. So I think this really summarizes the rationale for high KDPI kidneys rather well. And this is really a nice SRTR kidney transplant decision aid that you'll see on their website where you can put in the characteristics of your recipient, and then it'll give you a predicted outcome in 5 years. So for our patient who is at University of Chicago, 74-year-old with 5'6", 150 pounds, blood type O, PRA 0, and 1 year on the wait list, 1 year on dialysis after, so I put in all that. Basically, in 5 years, this patient has a 32% chance of getting a deceased donor transplant, 27% chance will still be waiting, and in 5 years, a 41% chance that she will die or become too sick for a transplant. So I think putting it in this context for every patient that we see is very, very important. So this is another very cool study by Dr. Schold and colleagues looking at the time to equivalent risk, basically, of a deceased donor kidney transplant versus death versus removal from the wait list, looking at over 200,000 patients. And what you see here is that for older candidates, the time to equivalent risk or titer becomes shorter and shorter. So for the people who are 65 to 69, that time period is 41 months. And for those who are 70 or older, that period is 28 months. So over time, cumulative incidence of death or waitlist removal exceeded deceased donor kidney transplant. And the folks that really have lower titers are those who are older, diabetic, blood type O or B, or shorter pre-listing dialysis time. So this is another nice graphic showing kind of what this study found, in that for candidates 65 or older, titer was shorter for kidneys from younger or lower KDPI donors. So if you had an older candidate who listed only for 0 to 84%, that time where the risk of death, waitlist removal versus deceased donor is actually a lot shorter at 11 months. Compared to if they listed for 0 to 100%, it's actually longer at 25 months. So a large proportion of waitlisted patients in the US actually have a very poor prognosis to even undergo transplant. So again, like I said, we feel good, we've approved somebody, they're on the waiting list, but the chances that they will actually get to a transplant are probably not very good. And as you can see here, this is Dr. Lentin's paper of the OPT and SRT, our annual data report, that the proportion of candidates willing to accept a kidney with high KDPI has actually declined in all age groups in 2021, continuing that decline since 2014. And half of candidates aged 50 to 64 and less than 2/3 of candidates aged 65 years older were willing to accept these kidneys. So there's a lot of patients out there who are not listed for these kidneys. So very quickly, reviewing the data of post-transplant survival benefit of these high KDPI kidneys. This is a paper from Dr. Massey and colleagues, SRTR data from 2002 to 2011, 184,000 patients, and looking at basically the mortality risk of high KDPI kidney versus a conservative approach, which is to remain on the wait list until receiving a kidney with a lower KDPI. So no surprise here is that high KDPI kidney transplant was associated with increased short-term mortality, but over the long term, it decreased long-term mortality risk. And looking at the time to equal risk and equal survival, you see here on the table, for this 91 to 100, for example, the time to equal risk is 7 months, but the time to equal survival is up to 20 months. And they have this nice algorithm of who benefits from these high KDPI kidneys. Essentially, the benefit is greatest in patients who are greater than 50. I'm not going to call anyone over 50 old by any means, but it is in 50 years or older. And patients at centers with median waiting times at 33 months or more. This study is nice in that it shows you that preemptive transplant with high KDPI kidney actually provides immediate benefit compared to a conservative approach. So you see here that the hazard ratio for death at 0 to 1 years in a preemptive kidney transplant over 85% was 0.61 compared to waiting for the next kidney on the waiting list with a lower KDPI. So I think the take home here is that when you have a patient who is especially preemptive, not on dialysis, a high KDPI is a good way to go. What about quality of life? This is a study at my old institution. We looked at physical component scores and mental component scores of the SF-36 and found that increasing kidney donor profile index sequence does not adversely affect medium-term HRQOL after kidney transplant. So the red is the sequence D or greater than 85% kidneys, and you see there is a drop at about 5 years or so, but for the most part in that period, post-transplant up to medium-term, 3 to 5 years, quality of life was acceptable. So back to the case, she consented to KDPI greater than 85% kidneys after 6 months on the wait list. She actually receives a deceased donor offer with a KDPI of 96%. So the number is scary. But there are decision aids out there. This is a paper, again, from the same group as from Dr. Bay and colleagues, looking at basically what is the prognosis when you match EPTS and KDPI. And I'm showing this to you from the website of the transplantmodels.com, where you can plug in a patient's EPTS and a kidney KDPI that's being offered to you. So our patient's EPTS was actually 96, and the offer was for a 96 KDPI. So for this patient, the predicted 5-year survival if the candidate remains on the wait list is 39%. If the patient receives this 96% KDPI kidney, the 5-year survival is 57%, conferring a survival benefit of plus 18%. So at least based on these statistics, it seems like we should go for it. So the offer is for a DCD, dual kidney transplant. And it was actually biopsied, and these were the biopsy results. As a single kidney, this is very highly likely to be turned down with 22% glomerulosclerosis, 25% glomerulosclerosis. Pump numbers were good and acceptable, not the best, but good enough. And so just a quick background of what dual kidney transplants are. So essentially, both kidneys are offered by the OPO to one center. So if they think that this single kidney will be turned down or cannot be placed, then they're offered as 2 kidneys. And this single center study by Dr. Das and colleagues did show that outcomes of dual kidney transplants from high KDPI kidneys are superior compared to single kidney high KDPI transplants. You see here the GFRs at 1 year and 2 years are higher with a dual high KDPI. So essentially providing enough renal mass for the recipient for these kidneys to have longevity. So back to this patient, she got transplanted. The cold ischemic times were 23 and 24 hours, warm ischemic time 21, 23. She actually received dialysis on post-op day 2. Her fistula clotted. The decision was made to go to IR and declot it rather than to put a line in. As needed, she received 1 more session of dialysis. Her kidney was biopsied 5 weeks post. She had some acute tubular injury, some glomerulosclerosis, and IFTA and arteriosclerosis, which is not surprising. She had 1 admission for C. diff, which was a 3-day hospital stay. And I saw her in clinic last month. Her 3-month post-transplant creatinine is 1. She's currently on Tacro with a goal of 6 to 8, MMF 500 BID and PRED 5. So to end, I think it's very important to also just talk about what do we do when we accept these high KDPI kidneys, what are management strategies to think about. You know, the data on what to do for delayed graft function, there's not a lot we can do, but there is some that we can do. So obviously reducing cold ischemic and warm ischemic time as much as we are able to reduce DGF. We know that the best fluids trial provided some evidence that balanced crystalloids are superior to normal saline as your perioperative fluid. And then the utilization of machine perfusion. I think a lot of surgeons are, leaning towards this. At least the feeling I'm getting in the community is there's more machine perfusion going on, and there is some evidence that can reduce DGF. In an elderly patient particularly, I think you have to be very careful about volume management, where you don't get into cardiovascular issues. You don't really want to get behind on volume. And then for elderly recipients, I think this has been discussed as far as reducing infections risk as much as you're able to. So in conclusion, the high KDPI kidney transplant provides improved survival compared to the conservative approach. There are decision tools available to aid in shared decision making, and we have to have careful management in the post-op period to mitigate short-term mortality risks.
I have a question. You do an extensive evaluation for elderly recipients. Who does this evaluation? Do you get geriatric involved? Is it social worker?
Yeah, so we actually are very fortunate. We have a geriatrician that's a part of the transplant team. So any patients who are 70 years or older is seen by our geriatrician. We also have the SAFE clinic that is part of the institution. So we have access to that resource where we can send the patient to the SAFE clinic.
Do you have a cut-off for age?
At University of Chicago, we do not.
Good question. Transitions. Thank you for
Yes.
the presentation. In your mind, what's the best objective for this?
I have a question. You do an extensive evaluation for elderly recipients. Who does this evaluation? Do you get geriatric involved? Is it social worker?
Yes.
Who does this evaluation?
Good question. Thank you for the presentation. In your mind, what's the best objective for this?
What is the best objective frailty test? I think I don't have an answer to that, unfortunately. I think every institution, it's a little hard, right? If you have the resources to actually do the testing, number one, is it even feasible to do it? So at U of C, we do a short screening. Every patient gets the question and answer, 5 questions. And then when we screen someone as potentially frail, then we send them to the SAFE clinic. So I think the best one is what works for your institution, what you're able to do.
Dr. Rahman?
Thank you so much. Following up on that, suppose this patient is 74-year-old plus remaining on the list and we got a transplant. How frequently do you repeat the evaluation?
Yeah, so
Specifically the frailty test.
Yeah, so I think for, again, this is institution dependent on how big your list is, how many people are older on your list, and what your staffing looks like. But where I am, we see them once a year. So we update the testing, we repeat the evaluation. We have sent some people for physical therapy and prehab, especially if we think that they're getting close to an offer. And whether that provides benefit down the road, I think that's an area of study that's actively being studied.
Yeah, just a bit of an interesting story, that perhaps the poster child for this KDPI kidney with a dual transplant was actually the conductor, Kurt Mazur, of the New York Philharmonic, who basically was about to, had renal failure, was on dialysis, gave up conducting, and basically said, that's it. Someone told him about this prospect for receiving a transplant. He did, and conducted for another 8 years.
Interesting.
Thank you.
Interesting. Thanks for sharing. Thank you.
Thank you.